On behalf of IIP technical team, I, Dr. Uttara Mohan, welcome you to this webinar on role of physiotherapy in labor and delivery. We are streaming live on IIP India YouTube page. So please subscribe to this page to get regular updates about our webinars. So now I ask the organizers to please start with the session.
Thank you, Dr. Uttara. Good morning, one and all. I welcome you for the webinar series, Day 3, Webinar 4. We welcome our speaker, Dr. Snigdha Mehta. And the topic for today's webinar is Role of Physiotherapy in Labor and Delivery. This webinar series is jointly organized by IIP Women's Health Satara District, Maharashtra, in collaboration with Krishna College of Physiotherapy, Karan. I would briefly like to describe IIP Women's Health. IIP Women's Health was started on 30th of May 2018. It functions under the guidance of National Head Dr. Ruchi Vaishne and IIP President Executive Dr. Sanjeev Jha. IIP Women's Health works towards conducting public awareness camps, CMEs, workshops. It aims at bringing together all physiotherapy professionals for sharing knowledge and improving public awareness about physiotherapy. We have 5 zones in India with the heads of each. And for the West zone, we have with us Dr. Pooja Kamble. The state team of IIP Women's Health Maharashtra includes the state coordinator, Dr. Suvarna Gandhir, joint coordinator, Dr. Snehal Patel, sub-coordinators as Dr. Uttara Mohan, Dr. Priya Karande, and Dr. Nirali Sangvi. In Maharashtra, IIP Women's Health has conducted 40 plus low-cost activities and N number of webinars in the past few months. In the first corporate IIP conference, which was held in Indore in April 2019, Maharashtra State received the award for the best state IIP Women's Health. Now, I would like to introduce the Satara team of IIP Women's Health who's hosting this event. It consists of 3 team members, Dr. Trupti Yadav as the coordinator and assistant professor at Krishna College of Physiotherapy, myself, Dr. Khushbu Chotai as sub-coordinator and assistant professor at Krishna College of Physiotherapy, and Dr. Pallavi Kulkarni as sub-coordinator. I would also like to describe and explain about Krishna Institute of Medical Sciences deemed to be university, which was established by the visionary founder, chairman and honorable chancellor, late Sri Jayawantrauji Bhosle, our beloved Appasar. Krishna Institute of Medical Sciences, deemed to be university, is flourishing under the guidance of Honorable Chancellor, Dr. Suresh Bhosle, Honorable Pro-Chancellor, Dr. Praveen Shingare, Honorable Principal Advisor, Dr. Ved Prakash Mishra, Honorable Vice Chancellor, Dr. Mrs. Neelam Mishra, and respected Registrar, Dr. M.V. Ghorpade. University currently has undergraduate, postgraduate, and super specialization in various disciplines such as medical, dental, physiotherapy, nursing, allied health, and pharmacy. It is also a host to 5,000 plus students on this environment-friendly campus. It has to its credit NABH, NABL, ISO, NIRF, and NAG-A accreditation. The university has excellent facilities for housing students in campus with state-of-art sports complex. College of Physiotherapy initially started in MUHS in the year 2002, and in the year 2005 and 6, the university achieved its team status. It currently has undergraduate, postgraduate, and interdisciplinary PhD programs. College is headed by Dr. G. Varadarajalu from its inception. Krishna College of Physiotherapy is a pioneer institute in Maharashtra with all the facilities as per the norms of IIP and Maharashtra State OTPT Council. I would now request Dr. G. Varadarajalu to kindly introduce the speaker.
Very good morning, one and all. It's my pleasure and privilege to welcome you all for the 3rd day of the webinar series for the 4th lecture on today's. For the 4th lecture, we have Dr. Snigdha Mehta Madam, who is a very senior physiotherapist. In fact, very first time, very recently, I heard about name and I'm very glad to invite her to be a part in this particular webinar series. We are all the junior physiotherapists in this country. We are very much obliged and privileged to have you as a lecturer, madam. About Dr. Snigdha Mehta, madam, there are a lot many things to say. The time may not be permitting, but still there is a core areas I would like to introduce. She has undergone training. She is giving training for the teachers, training in pre and postnatal exercises, and certified American Physical Therapy Association in obstetric and advanced techniques in labor support, and fundamental and advanced pregnancy and postpartum physical therapy, Austin. She is certified by American Physical Therapy Association in pelvic and pelvic health physical therapy in level 1, level 2, received training from more than 20 internationally renowned physiotherapists in musculoskeletal physiotherapy like Shirley Sharman, advanced level, kinetic control, level 3, Brian Mulligan and others. Scholarships, offered scholarship by APTA for pelvic pain and bowel dysfunction course in 2019 in USA. About teaching, conducted more than 30 workshops in obstetric physiotherapy. About clinical experience of madam of treating thousands of orthopedic patients, elite athletes, pregnant, postpartum women, and women with pelvic floor problems for more than 40 years. Really, madam, we are blessed to have you as a lecturer for this particular session. We wholeheartedly, on behalf of our university, on behalf of IAP, Indian Association of Physiotherapy, Women's Cell of Maharashtra, Satara district, once again, we wholeheartedly welcome you, madam, and over to you, madam.
Thank you. Okay. So thank you so much, Dr. Varadaraj, for that nice introduction. I'm thankful to IAP India, IAP Women's Cell Satara, and Krishna College of Physiotherapy for inviting me for this webinar. Mine has been a long journey in women's health. I've been doing women's health for more than 30 years now. And I like to be constantly updated. So every year I do new internationally recognized courses. And the more I learn, the more I'm eager to learn. And the more I feel I don't know anything. So it just goes on and on. And today, of course, I'm going to talk about, can you hear me, everybody? Can you hear me?
Yes, madam. Yes, madam. Yes, absolutely. Is it audible, madam?
You could hear me earlier?
Yes, ma'am, it was clear.
Okay. So yes, the hunger for learning never stops. And so today I'm going to talk to you about the role of physiotherapist in labor and delivery. How can we help in this field of physiotherapy? So can I do screen sharing now?
Yes, ma'am.
So are you able to see the screen, everybody?
Yes, yes, ma'am.
And you are able to hear me?
Yes,
right?
Yes.
Okay, great. So I begin. Okay. Yes, so today I'm going to talk to you about the role of physiotherapist in labor and delivery. So we are very fortunate to be living in an era where science of obstetrics has progressed tremendously, and excellent medical care is being taken on prepartum, intrapartum, and postpartum period, so that mothers and babies are no longer at risk. But while it is very important and essential to have excellent medical care during this period, it is not enough. Historically and cross-culturally, over different countries, women have had other women supporting them during the labor and delivery. However, since the middle of the 20th century, we have found that majority of women give birth in hospitals, and continuous support by a person trained and known to her during labor has become the exception rather than the routine. A Cochrane review done by Hodnett in 2012 on continuous one-to-one support for women during childbirth over for 15,288 women, 22 RCTs, and 16, it was spread over 16 countries. So what was the outcome of this review? The maternal satisfaction improved, increased chance of spontaneous vaginal birth, less use of regional anesthesia, shorter labor, and no adverse outcomes. Another study done by Kloss in 2002 indicated that shorter labor, the labor decreased by 25%, and reduction in Pitocin use decreased by 40%, in analgesia use by 30%, epidural by 60%, forceps delivery by 40%, and cesarean delivery by 50%. That was a huge, huge difference of one-to-one support given to the woman who was laboring. So let me first introduce you to what is normal labor. So World Health Organization defines normal labor as spontaneous onset of labor between 37 and 42 weeks of pregnancy, low risk at the start and remaining so throughout labor and delivery. Spontaneous birth of an infant in the vertex position, and mother and baby in good condition after birth. So that's the normal labor defined by WHO. What are the stages of labor? So we have what is called pre-labor. In this, we have mild, non-progressive contraction, also called Braxton Hicks. These contractions are not progressive in terms of frequency and duration. They may come, they may go away, and there is no progress at all. And they may begin as early as second trimester. And then we have the first stage of labor, which is the latent phase. A woman may not be aware of this latent phase. So she gets cervical effacement, as you see in the diagram. The cervix becomes thinner and dilation can be up to 6 centimeters. Loss of blood-stained mucus may occur during this period, and the contractions are mild to moderate, and there could be amniotic fluid loss during this period. What are the early signs of the onset of labor that a woman would recognize? Pain and discomfort, which we often see in all these movies, could be in the back and lower abdomen, and most women at a very young age are familiar with this sign of labor. But they may not be familiar with that mucus plug, which could be blood stained, could leak as the first sign of labor. There could be amniotic fluid leak or gush as a first sign of labor without the pain. And there's one symptom that they do not recognize is sudden frequency to need to visit the restroom. So all of these signals would indicate that the woman could be beginning to go into labor. This is the occiput anterior position. This is the perfect position, whether it's right or left occiput anterior. This is the perfect position in which the baby is now placed, ready, all ready, and all set for the delivery. So the first stage and the active stage after the latent stage, during this time, the dilation of cervix is 6 to 10 centimeters, and the contractions are about 5 minutes apart and each lasting for about 1 minute. The fetal head starts to descend, and coping strategies have to be used during this period. During the first stage, we have the last part of active stage, which is called the transition. During this time, the 8 to 10 centimeters dilation takes place. Contractions become 1 to 2 minutes apart, and they last for almost 1 to 1.5 minutes. mother may feel nausea, irritability, anger. Stress can increase duration. Then we go to the second stage. Second stage is from the dilation of the cervix, from 10 centimeters dilation to the birth of the baby. And during this, the latent phase. All these stages are extremely important for us physiotherapists to know, because when do we help the woman to push? When do we help the woman to do the breathing and all that, which I'll be talking about soon. So the second stage begins with the latent phase. In this, the woman does not feel any urge to bear down or push. And it is advisable to allow the mother to conserve her energy and wait for natural bearing down reflex. This is important to know, because many women think as soon as they're 10 centimeters dilated, they should start pushing. And during this latent phase, compared with babies of mothers who pushed immediately after full dilation, babies of mothers who labored down or just relaxed while they were in the latent phase of second stage had less problems with their heart rate decelerating and had better oxygen levels. These are extremely important information that we physiotherapists should know about. And then we go to the second active phase. Strong desire to bear down in a woman, and unless an epidural is used, then of course the desire may not be strong enough. During this phase, 7 cardinal movements of the fetus occur: the engagement, descent, flexion, internal rotation, extension, external rotation, and ultimately expulsion. So these are the various stages of the second stage, active stage of labor. And then we have the third stage, from birth of baby to delivery of placenta. And the fourth stage, which is equally important, from delivery of placenta to stabilization of the mother's condition. Let's also learn about dystocia or dysfunctional labor. What is that? So it could be protracted or arrested labor. That means the cervix is not dilating, or the baby doesn't come out in the second stage. Or there could be an abnormal position of the fetus, because of which there's a dysfunctional labor. Or the baby may be asynclitic. Asynclitic means the head is tilted to one side, the ear is more towards one shoulder than the other, and this also causes a problem of the baby coming out. And then we have the occiput posterior positions. That means the occiput of the baby is facing in the posterior direction. There are some babies whose head is bigger than the mother's pelvis, or the shape of the mother's pelvis is such that they cannot expel the baby out. So this is called cephalopelvic disproportion. And then you have the fetal shoulder dystocia, where one shoulder gets stuck and won't come out. All of these problems lead to dystocia. But there's another way in which we can define dystocia. It depends on the power of the uterine contraction. So weak contractions cause dystocia. The passage, the P's, the 5 P's are important. The passage is the size, shape, and joint mobility of the pelvis. What is the pelvis mobility and shape and size is important. And also what is the strength and resilience of the vaginal canal. All of these, when not optimum, cause dystocia. And then the passenger, the fetus is very important. The size and shape of the fetal head, the fetal presentation and position, as I talked to you earlier. And pain, whether the woman is able to cope up with pain. When she's not able to cope up with pain, she will tighten her vaginal area or perineal area, and she wouldn't let the baby come out. And what is the emotional state of the women? All of these things, the pain, the psyche, we can help the woman, make her more comfortable and make her delivery more easy. Other common underlying factors that are often missed: a full bladder and dehydration. And I'll talk about it soon. So what is the role of a physiotherapist during labor and delivery? Physiotherapists can work with obstetrician to coordinate safe, collaborative care, which is extremely important for women by teaching coping strategies and empowering a pregnant woman and her partner with techniques she can use during labor and delivery. That will enable her to have a more comfortable, easier, shorter labor and to have a normal delivery as far as possible under the circumstances at that time. So what can a physiotherapist teach both the mother and a partner? Perineal massage, breathing and relaxation techniques, other comfort measures like hot pack, cold pack, TENS, facilitatory positions, movements, abdominal and back massage, education about dehydration and full bladder, techniques to deal with asynclitic baby, hands-on techniques to reduce pain, modifying positions during labor if the mother has problems like spondylolisthesis, disc herniation, ankylosing spondylitis, and neurological problems, and many more. So in this webinar, we are not covering the 8, 9, and 10. Maybe sometime in future, we will do that. So the preparation for labor, when does it begin? It begins with a good prenatal exercise program. Right from day one, when they come in to us, if they have no medical problem, they can start coming at 14 weeks and we put them on an exercise program that's safe. And we are the exercise specialists, so we should know what exercise we can give them. And then we start teaching them relaxation techniques, breathing techniques. If they've done all of these throughout their pregnancy, unless they're contraindicated and not able to do them, they are better able to physically and mentally cope with labor. Those that are on bed rest find it more difficult. Those who have complications find it more difficult. But most women, almost 85% of the women, should have normal deliveries and normal labor, prenatal program, and they are able to deliver, better able to physically and mentally cope with labor. So these are some of the exercises or asanas that we like them to do. So the Baddha Konasana, squats, Parigasana, and there are many more that I start teaching them in the 3rd trimester. Of course, they do all kinds of prenatal exercise right from the 14 weeks till the 3rd trimester, and they continue doing all the prenatal exercises. But in the 3rd trimester, I start emphasizing on these kind of exercises or asanas. When they're at about 34 weeks of pregnancy, after they consult and the obstetrician gives permission, I teach them perineal massage. So perineal massage should be done once a day and for about 5 to 10 minutes. Contraindications are vaginal bleeding and infection. The purpose of this perineal massage is to prepare tissues for vaginal delivery by increasing the compliance or elasticity of the perineum so that it stretches more easily and less painfully, helps to focus on letting the perineum open up during labor and reducing the risk of tearing. And this perineal massage, according to my experience, has helped many a woman have a more comfortable second stage. I also involve the partners in breathing and relaxation techniques because it's the partner who is the mentor for the laboring woman. And if the partner is not able to teach the woman relaxation techniques while she's in labor or do the proper breathing and guide the woman in labor, then so in every session, the partner is called and relaxation and breathing techniques are taught to the partner. Rhythmic breathing and moaning are important, and the benefit of it is that when you do vocal breathing or moaning, Along with relaxation, it has immense pain relieving capabilities. And you start when you're unable to distract yourself when you are getting the contractions. There are two basic rhythmic breathing patterns for the first stage. So slow breathing and light breathing. What is slow breathing? As the contraction begins, give a long, relaxing sigh or moan and gently breathe in. And again, give the long sigh, exhalation, and repeat at the rate of 5 to 12 breaths per minute. So you take a breath in and you give a long breathe out as if you were moaning. And then you breathe in and you again give a long exhalation as if you were relaxing in the breath out. And what is light breathing? This is a mouth breathing, something like panting, breathing in and out through the mouth, silent breath in, but audible exhalation. The rate is about 20 to 60 breaths per minute. And she should be able to breathe at the above rate for about 1 to 2 minutes without feeling dizzy from hyperventilation. Both these breathing techniques, I make them practice during the prenatal period. And I also teach the partner both these breathing techniques so they can guide in case the pregnant woman forgets all about it during her labor. So this is a little faster breathing, and you're breathing in and breathing out, breathing in and breathing out, breathing in and breathing out. Every time you're breathing out, you're relaxing more and more. The advantage of this breathing is that you have to completely pay attention to this breathing, and it is very useful during the peak of a contraction. So you can begin with a slow breathing and then start doing light or panting breathing. And again, when the intensity of contraction decreases, you want to go back to the slow breathing, you can do that. This kind of breathing you can't do for a long time. Slow breathing you can do for a long time. And this breathing also, because it's from the mouth, sometimes your mouth feels dry. So sips of water are absolutely okay between contractions. And when you enter the second stage, we have the latent phase and the active phase. During the latent phase, there's a lull in uterine activity and there's no urge to push. Though your cervix is completely dilated, the urge to push is not there in the woman. And then we have the active phase where there's an involuntary urge to push and descent of the baby. So during the latent phase, it's extremely important to know that the forceful pushing should be avoided before the cervix is completely dilated, but also forceful pushing should be avoided even after the cervix is completely dilated in the latent phase of the second stage. A change in position, suppose the woman feels that she needs to push, she just cannot control the pushing urge during this phase, then she can change her position, and an all fours position or a quadruped position helps in this case. And when they enter the active second phase, the pushing or the bearing down techniques can be taught by us. So there's a spontaneous bearing down technique, and then there's a self-directed pushing and a directed pushing. In spontaneous bearing down technique, the involuntary urge to push is so strong in the woman that the woman spontaneously bears down and pushes naturally. And this is absolutely fine. This is something that we would all encourage. And then we have the directed pushing. This can be used when the baby's descent is too slow and the mother is unable to do the spontaneous bearing down. And the doctor is considering assisting the delivery with instrument forceps or a vacuum extractor. When the mother has been given epidural and cannot fully feel the urge to push, she also will not be able to do the spontaneous bearing down pattern. So directed pushing, which is very useful in certain condition, was introduced in the 1950s but is being used even now in some centers. Unfortunately, all women should not be doing directed pushing. And because it involves prolonged breath holding and straining, and hence has a lot of adverse physiological effects on both the mother and baby. So what are the physiological effects of direct pushing? It lowers the maternal arterial blood pressure, decreases maternal blood oxygen and increase in carbon dioxide levels. Sudden increase in blood pressure as she gasps for air. There could be perineal trauma, maternal exhaustion, buildup of lactic acid, and fetal hypoxia and acidosis. So this kind of direct pushing is not recommended for each and every woman. So these effects are most of the time tolerated quite well by young, healthy women and by well-nourished term fetus, but often not so by older women, high-risk women, those with weak pelvic floor, preterm fetus, and fetus with small gestational age. So we can teach them modified direct pushing. So what is this? When the contraction begins, the mother breathes in and out 2 to 3 times, letting the contraction build up. And then she breathes in and pushes as she exhales. 1, 2, 3, 4, 5. She then relaxes for a short time and repeats. So let's do it. Breathe in and out. Once more. So this is extremely good method of pushing compared to the directed pushing because there's no straining and there's no holding of breath in this method. Let's talk about facilitatory positions and movements that we can help the woman with during labor. How do they help? They improve the drive angle. They improve the efficiency of contractions. They facilitate the fetal descent, facilitate maternal fetal circulation, decreases maternal pain, can assist in rotation of fetus into OA position, occiput anterior position, decreases perineal trauma, and there are fewer chances of episiotomy, or the episiotomy cut is lower or smaller. So what is this drive angle? And all of these things we can help the laboring woman with if we teach them earlier in the prenatal period. The drive angle is the angle formed by the not know when admitted to the hospital. They lie down and they just relax and bear the contraction. So we have to train them. The woman in the picture below, you see the drive angle is much better. The gravity is helping her and she's leaning forward. So the drive angle is much better for her to progress with the labor. As you see in this picture, the first picture is standing. Gravity will help in the contraction because of the angle in which the mother is. And when she leans forward, the angle gets even better and it will help her even further. But lying down supine, as most mothers do, if not trained or not guided, gravity helps very little in the progress of the contraction and of the labor. And this is a position, unfortunately, often women lie down in, or they are asked to lie down this for a long time during the second phase of labor. In this position, It restricts the sacral nutation and pelvic outlet diameter becomes smaller. So this position is not recommended. Unfortunately, many women, especially in the second stage of labor, are asked to lie down for a long time in this position. And we also call it the lithotomy position or the semi-recumbent position. And they get immense amount of pain, but the baby won't come out. So but this position is comfortable for most obstetricians. So if you want to lie down in this position, what you tell the mother is that last minute when the baby is about to come out, which just takes a few minutes, you lie down in this position, but the rest of the time, if you are in the labor room, then you can lie down on your side, you can lie down on all fours, but definitely not in the position which restricts sacral nutation and restricts the size of the pelvic outlet. What are the facilitatory positions they can do throughout the first stage of labor? As I told you earlier, they can take support for standing, and leaning forward and standing are great positions. So gravity helps, it shortens the contractions and makes them more productive, relieves back pain because the pressure on the back decreases when they are in this position, and it's easy to massage the back in this position by the partner if needed. Then we have a quadruped position. This is another great position for the mother. It helps again to relieve back pain, and it allows for pelvic rocking and body movement and takes pressure off hemorrhoids. Many women during the prenatal period get hemorrhoids or piles, and this position helps them to decrease the pressure on those hemorrhoids. And of course, they can use a ball or they can put their hands on a chair so that they do not get too much pressure on their arms. And it is more relaxing to be in this position, quadruped position. And then we have the side lying positions. So if the mother is tired and she wants to relax, she can lie down on her side in either of these positions, and it helps to lower elevated blood pressure in case the blood pressure is going up, and it's safer than standing or quadruped if epidural is given. Sitting positions are great too. And of course, leaning forward in the sitting position is even better. Again, it relieves back pain, they are restful, and gravity benefits are also there. And this is another position, so I'm giving you lots of positions and a variety of positions, and mother can take up whichever position she's most comfortable in. Squatting is another great position because it opens the pelvic outlet by up to 30% compared to standing. Gravity helps the baby to descend, and advantage of upper trunk pressing on the uterus, and requires less bearing down effort. So how often should a mother change her position? It is advisable that mothers should change her position in first stage at least every hour, and preferably every 20 minutes. Frequent position changes in labor optimize the chance of a good fit between the fetus and the maternal pelvis, helping resolve problems like occiput posterior position, asynclitism, and deflection. And how does the woman know that this is the position which is better than the earlier position? Immediately she will feel less pain because the fetus and the pelvis are now better aligned, and therefore there's not so much struggle for the fetus to come out. And the woman will, when she changes the position into the optimum position at that time, she will immediately feel much better. So that's a way of knowing that this is the correct position for me at this point of time. Adding rhythmic movements helps even further. So gravitational advantage, rhythmic movements, when you add, they are more calming. They alter the relationship between the fetus and the pelvis and encourage the fetus to rotate into the occiput anterior position and help it to descend down. Sitting on a rocking chair, mother is tired, she wants to relax, she can sit on a rocking chair. That also helps if she can't move around too much. Swaying with the partner helps too. You can the partner can do a back massage during this time, and the woman in labor feels very comfortable if the partner is supportive. Swaying the pelvis in this position is absolutely a good idea. So movement is necessary during, especially during the first stage, but and also during the second stage if possible. What are the movements that help? Walking, duck walking, stair climbing. If she is unable to climb the stairs in the normal manner, she can climb sideways while holding the railing, but the repeated movement of the pelvic joints encourages fetal rotation and descent. So walking, I tell all my women to do this till the last days and also to do it during the labor. Duck walking. Many a woman has had a normal delivery because of being very active during her labor and doing all these movements and change of position as I just talked to you about. So movement is the key. No single position is optimal for all situations and for hours at a time. Therefore, the woman should be encouraged to move, try various positions, and not to remain in one position when there is no apparent progress for long periods. And in all of this, the partner, if he or she, the mother, the sister of the pregnant woman is trained, then it can help her a lot in guiding her and reminding her about change of positions. Further, we are expert at massage, and massage done by the partner helps even more. So a report by National Institute of Health USA, in a study of labor pain, women who received massage therapy experienced significant less pain. Their labors were on average 3 hours shorter and with less need for medication. The most important finding was the lower incidence in babies of prematurity and lower birth weight, and postpartum depression also decreased in these women. The newborns of the massage mothers had lower cortisol levels because the mother had lower cortisol levels than the mothers who were not massaged. They performed also better on the Brazelton neonatal behavioral assessment. Massage can be done by using the whole hand, fingertips, thumbs, heel of the hand, back of the hand, tennis ball or soft ball. And we are all experts in this. So massage should not be done only on the back or abdomen. It can be done on the foot, shoulders, forehead, hands. Useful even in case of epidural. The mother can indicate with non-verbal communication should be happening between the mother and the partner, and she could indicate which part of her body, if the partner massages, she will feel better. So these are some of the positions with massage techniques added on which help a lot. There's another thing I want to talk about, drinking fluids and emptying bladder. So throughout the labor, the mother is encouraged to drink fluids and encouraged to empty her bladder. So a woman in labor uses up a lot of water because of her body quickly. She loses up the water in her body quickly, and she also uses up a lot of energy. So during the first stage of labor, she should be reminded to drink 1 cup approximately of water every hour. And this could be any other fluid if she wishes to have any other fluid. If she does not drink enough, she may get dehydrated, making her labor much longer and harder. Dehydration can also make a woman feel exhausted. And this is a very common cause of dystocia or difficult labor. Also, the woman should be encouraged to urinate at least every 2 hours. If her bladder is full, her contractions may get weaker and her labor longer and more painful, because already the baby is pressing on the to go down, and then there's a full bladder. So you have to, the partner is told or taught to remind the mother to urinate because she may not remember to do so. So what's the take-home message of my webinar today? Physiotherapists can play a major role in helping the mother cope with the pain of labor by educating her and her partner about breathing techniques during first and second stage, relaxation techniques, facilitatory positions, movements, massage. I dedicate this presentation to all the women who have allowed me the distinguished honor of utilizing my skills and knowledge to guide them in their antepartum, intrapartum, and postpartum period. I have many such pictures, and this is the sweetest thing that can happen in my life. Thank you. Yes, life is beautiful. Thank you, everybody.
Very nice presentation, madam.
Thank you.
And it is very knowledgeable and newer
Thank you.
for a majority of the physiotherapists across the country. In fact, nobody will be interested to work in this particular discipline. You have taken your efforts, and because of you, this particular branch of physiotherapy is hope so it is flourishing in our country, madam. We are
Yes,
happy
that
to.
is my aim.
Yeah, we are. It is really knowledgeable and easy, simple to understand. I think the all women physiotherapists should take it as an motivate. They should get motivated out of this lecture, and they should practice this particular branch of physiotherapy, which is an outcome of this particular webinar series. Thank you very much, madam. I will allow Dr. Snigdha Mehta to take up the questionnaire.
Yes, sir. Hello. Hello.
Yes, Khushbu, are you?
Hello, can you hear me, ma'am? Smita
Yes,
here.
Smita, yes, Dr. Smita.
Ma'am, we have some few questions.
Yes, sure.
The first question is, what is difference between normal delivery and natural delivery?
I would say natural delivery means somebody who delivers without any aid, without any, like the women in the village maybe who are delivering without much of a support. So that's natural delivery maybe. But they also have a normal delivery. So a natural delivery can be quite normal, and a normal delivery can be quite natural.
Ma'am, the second question is, what is panting breathing pattern?
That's the light breathing. That's the breathing that can be done at the peak of a contraction, especially during the first stage. And that breathing, I am not too sure whether when I was actually demonstrating, you all could see it.
Okay.
You could see it, or no, you couldn't see it. We could. Oh, you could, right? Yeah. So that contraction, you have to build up so I can do it once more in case the person who has asked the question has missed it. So panting and light breathing are similar. So basically it's a mouth breathing, and you're doing a fast breathing. Your whole attention is on the breathing, and therefore it's taken away from the pain. And that is why it's extremely useful during the peak of the contraction. It's like this. Okay. Okay. You can ask me the next one.
Yeah. Do physios have some role in the abnormal positions of fetus?
Yes. So as I said in this webinar, I'm not going to talk about details about how we can help if they have asynclitic babies, or if they have occiput posterior babies. But there are certain positions which we can help them with, and we can train them to do those positions and movements. Of course, there's no guarantee that the baby will turn in the correct position and become synclitic. But definitely by guiding them, it does help them, prevent them from C-sections, from forceps, vacuum deliveries, so or a large episiotomy. So I guide all my pregnant women with all these techniques. But today in this webinar, we are not covering those techniques because of shortage of time. And some of them are hands-on techniques, which of course I cannot cover in a webinar.
Thank you. The next question is, how does TENS facilitate normal delivery?
TENS?
Facilitate
TENS?
normal delivery.
So TENS, I don't use frankly TENS a lot, but TENS can be used. It is researched, and you put two channels. One you put on T10 to L1, and the other on S2 to S4. And a lot of women do get pain relief with TENS during their labor. But in our country, normally you have to have they have to buy their own tents. So that is why it's not very convenient for us to use as much as in the Western world they use.
And regarding TENS, there is another question. If TENS is used during labor, then how long it should be used, and what is the mode that we should choose?
So as I said, I'm not an expert in TENS. I'm not an expert in electrotherapy. Okay, so I don't want to answer a question which I don't normally use.
The next question is there any role of physiotherapy for hypertensive pregnancy?
For hypertensive.
Pregnancy-induced hypertension.
Pregnancy-induced hypertension. Okay. So again, this webinar doesn't cover complicated pregnancies. There are some amount of physiotherapy. Depends on how much the blood pressure is, whether it's 120 by 80, 130 by 90, or 140 and beyond by 100. So actually the obstetrician is extremely important to decide how much bed rest this lady requires, and whether it's a complete bed rest, she can't get up at all, and she has to have her legs elevated, or she's allowed to move around, or she's allowed to do light exercise. I've often taken girls, in fact, right now I have in my class a girl whose blood pressure is slightly elevated. So I always tell her to take her blood pressure before the exercise and after the exercise. And if it crosses 130 by 90, I would not make her do the exercises. So, so blood pressure is a very important criteria. And for every single woman who comes to us, once a week, her blood pressure is taken by us, so that we know what is the weekly change of blood pressure. And we need to monitor the blood pressure very closely. Every week they do not monitor otherwise, but when they come to us, they can monitor it every week. And it is important to monitor the blood pressure.
Our next question is, many hospitals do not allow partners during labor. So
Or
what
they
is
do
the
not allow, sorry?
partners during the
Partners.
labor?
Yeah.
So what is the alternative way of relaxation or massage for a lady during first stage?
So, if they do not allow, then they can do a massage with the ball standing against the wall, with the ball standing against a wall. They can do a self massage, or they can do it with their hand on the abdomen by their hands. Those are alternatives that can be done. Yeah.
The next question is, duck walking should be practiced after which week of pregnancy?
After,
Which week of
sorry,
pregnancy?
duck walking. Okay.
Yes.
So duck walking can be started only after the woman has started doing squats. So being musculoskeletal physiotherapist, I always tell them to begin doing squats in front of me, because I find that some of the women who have not been guided by us and have gone to other places started doing squats on their own and started getting knee pain, etc. So I always first teach them squats in front of me, which could be quarter squats, half squats, and then go deeper. And always before starting squats, I would take the obstetrician's permission whether the squats can be started. So all obstetricians have a different take on this. Some of them say very early, yes, you can start squats, and some of them won't. Also, every pregnant woman is different. So what is the position of the baby? If the baby, for example, is breech, I would not start squats. Okay, so starting squats, and then we come to duck walking. If everything is fine and she's been doing squats for a couple of weeks, Then I would start duck walking so that the forces on the legs are not very high and she's able to do. On the other hand, there are women who would tell me, I have done squats my whole life. I use my Indian toilet. I sit on the floor and do all my tasks. So these are the women who can be taught squats very early if their pregnancy is completely normal.
Our next question is, which all position is useful in a woman who is having a sacral pain?
Sacral pain?
Yes.
When you say, you mean sacroiliac joint pain?
Yeah.
So sacroiliac joint pain is because of many reasons. It could be because of ankylosing spondylitis, or it could be a mechanical dysfunction of the SIJ joint. So all of these things have to be, so if it's a mechanical dysfunction of the SIJ, then we have to correct that during their pregnancy as much as possible. And a lot of such women we have treated with such problems, pubic problems, SIJ problems during their pregnancy. So by the time they are ready to deliver, their pains are much less and they're able to deliver more easily. Also, a lot of women who have, as I said earlier, spondylolisthesis or hip joint restrictions, they are not able to externally rotate the hip joint. So all of these things should be treated in the prenatal period in collaboration with the obstetrician.
Our next question is, how can we differentiate latent phase and active phase in second stage of labor?
So in the latent phase, the urge to push is not there. It's a quiet phase. It's like suddenly everything seems to be quieter. The contractions may be there, but the urge to push, the natural drive. Any woman who has delivered knows that urge to push is so strong when actually the baby is coming out that they cannot miss it. So the urge to push is not there in the latent phase, whereas in the active phase, the urge to push is very strong, unless of course epidural is given. If an epidural is given, then of course the urge to push is not there or not strong enough.
Our next question is, can relaxation techniques like progressive muscle relaxation be taught?
Sorry, I couldn't hear. Can you repeat it, please?
Can relaxation techniques like progressive muscle relaxation be taught to a pregnant lady?
Progressive muscle relaxation. Yes, of
Yes.
course. Yes.
Next question is,
Can we just, we had enough of question answer session. It was really very interactive. Yes, we are just running short of time. I think
That's what I thought.
Yeah. So if we have some queries, probably they can mail you or something like that.
Yeah, they can email to me maybe, or
yes, surely.
Yeah.
So thank you so much, Smita. Thank you so much, Snigdha ma'am, for this wonderful question answer session. I would just like to interrupt, and I'm glad that we have with us Dr. Ruchi Varshne, who is National Head of IIP Women's Cell. We are very glad to have you, ma'am.
Thank you. Thank you so
Would
much.
also like to hear from you a few words.
नहीं, स्निग्धा मैम का सुनने के बाद मुझे कुछ बोलने के लिए नहीं है. मैम, you're amazing. And today I got a call after this. जब ये webinar चल रहा था, तो मैम आपको याद होगा IPH में HOD थे OT के वीना स्लैच मैम. And she said कि you all are doing fantastic job. स्निग्धा मैम का मैं live सुन रही हूँ YouTube पे. So मैम, the entire country was watching. Thank you so much. Thank you to IAPWC Maharashtra team, मैम जैसे legends को इस platform पर लाने के लिए. So Varna मैम, thank you so much for inviting me. And IAPWC Satara team, Vardaraju sir, thank you so much. I think मैम आप जैसे लोग शायद ये की स्टेक होल्डर्स हो गायनी को स्पेशलाइजेशन फिजियोथेरेपी में और आगे इस कंट्री में एक बड़ा लेवल पे लाने के लिए. और मैं चाहूंगी मैम आप इन चीजों को और आगे लाओ और ज्यादा हम लोगों को इंस्पायर करो कि हम लोग और ऐसे कोर्सेज को ऑल ओवर कंट्री कंडक्ट करें. बिकॉज कहीं ना कहीं मैम गायनी की सीट्स सेमेस्टर्स में खाली जाती है, कई कॉलेजेस में, कई इंस्टीट्यूट्स में, यहाँ नॉर्थ में ऑर्थो एकदम फिल हो जाता है, न्यूरो फिल हो जाता है, बट देन कमिंग टू गायनी इट इज समवेयर लगता है लोगों को कि शायद जॉब्स नहीं है, शायद फ्यूचर नहीं है, शायद करियर अपॉर्चुनिटीज कम है, बट विद सच काइंड ऑफ कोर्सेज आई फील ये बहुत ऊपर जा सकता है और एक बूम आ सकता है इस फील्ड में. सो मैम प्लीज कीप टेकिंग सच काइंड ऑफ webinars and courses in the country, and we are honored to have you on this platform.
Thank you so much, Dr. Ruchi. It's a pleasure to meet you. And I've heard so many good things about you that I'm so impressed with all the things that I've heard about you. And anytime you need my help, I'm always there, anytime. And yes, I've been doing this for 30 years, women's health. And I would love to do anything for our professional colleagues.
Thank you so much, ma'am. Thank you, everyone. Thanks to all the participants to join in.
Thank you so much, ma'am, for joining us and sparing your valuable time.
Thank you.
I would now request Vararajan sir to take over.
So really, it is a pleasure to meet all the legends in the field of physiotherapy. Today, especially, we had a great lecture from Dr. Snigdha Mehta madam, and I could see Ruchi Varshini madam joining in the end and giving colors to this particular lecture. And Swarna madam is very sincerely attending from the beginning. Every day I could see her involvement in this particular webinar series. And wholeheartedly thank each and everyone who is participating, who is supporting for the great success of this particular webinar series. Once again, I thank Dr. Snigdha madam for your valuable contribution, valuable time that you are spending for this gracious lecture. And thank you one and all. Thank you very much.
Thank you so much, everyone. With this, we end our webinar.
Thank you, everybody.
Thank you to the technical team. Thank you, Uttara, for the support throughout. Thank you, Snehal. Thank you, everyone.
Thank you, ma'am.
Thank you.